Hello and welcome to this talk in this first session covering Nourishing the EDS Body, where we're going to be exploring the evidence around some dietary protocols. My name is Helen Spriggs and I'm a registered nutrition practitioner here in the UK, and I also lecture in nutrition research. I don't have any disclosures, and here's a little bit more information about me. And I'm also an active member of the Diet and Nutrition Working Group at the International Consortium for hEDS and EDS. So this session is, as the title suggests, looking at the evidence around dietary protocols in the context, of course, of EDS and hEDS. So by the end of the session, hopefully you'll be able to understand what the array and status of nutrition research is, being aware of some of the limitations around the published literature that we do have, and be able to think about the value of nutrition specialists being able to provide clinically informed care alongside the evidence that we do have. So, first of all, I just want to talk a little bit around the evidence and nutrition care and use some terms or bring to your attention some terms in this field that also apply to wider healthcare and also medical evidence. So evidence-based practice, which is referred to as EBP, or sometimes called evidence-based care, is a really key aspect of driving care standards across healthcare and also developing clinical guidelines. But there is some difficulties when we start to look at applying EBP into nutrition, and that's because challenges around researching nutrition and dietary protocols and interventions is incredibly complex, especially when we're trying to look at the effect on our health. So this is where combining both evidence-based care or practice with clinically informed care is really valuable to be able to allow clinicians to use their experience in specialist fields alongside the best evidence available that we actually have. Because a lot of the research that we can have isn't always directly transferable into a clinical setting. So I mentioned challenges in nutrition research, and these are just some, and I won't go through them all, but it's just to flag some of the considerations about, when people ask, why don't we have more research in this area? It's because it is a complicated one, and jumping down to funding, that's always first and foremost, is making sure there's actually funding available, and often when we're looking at medicines, well, they're researched and funded by pharmaceutical companies. There isn't a company behind diets per se. There may be around testing or supplement products or food products, but not around overall diet. But diets are also very complex to assess. We also have to take into consideration factors around geographical location, nutrient density, the long term, being able to study the long term effects of diet. Just being able to look at a diet for 4 weeks is never really going to be able to give us enough insight as to the impact of that long term on an individual's symptom or health condition. So these are some of the challenges that we often face when we're trying to think about how we can best research this. And the last one on that slide was individuality. And when we think about that in terms and the background of hEDS and EDS, we have to think about, well, are the individuals being studied in research? What condition do they have? But then what all other healthcare or health considerations do we have to look at? For example, dysautonomia, mast cell disorders, GI, and the list goes on. But individuals may have conditions that are not directly associated with a connective tissue disorder, for example, type 2 diabetes. And then there's lots of personal factors or confounding variables that we have to be able to consider. And these are often grouped within sample populations in studies, but what age, what geographical location, our individual genetics will also play a role. So we have to be very specific when we're researching, and some of these complexities make that specificity hard to achieve. So whilst I'm saying it's very difficult and can be very challenging to research nutrition in any field, but particularly when we're thinking here about EDS and hEDS, there is a lack of what we would refer to as primary data, so using population-based studies. So there isn't a huge amount to look at the specific efficacy of either specific nutrition interventions, so specific diets or dietary protocols, certain foods or food supplements. But nor do we have actually any specific data when we're thinking about, say, blood markers or blood reference ranges specifically for the EDS population. So with what we kind of are lacking, it makes it very difficult to have best practice guidelines, high quality data, or sort of clinical standards that are global. We might have some on a more local basis when we're looking specifically at EDS and HSD, because a lot of the research that we do have is looking at specific co-occurring conditions. And there's some here just listed on the screen around dysautonomia or mast cell disorders. Or the research is actually looking at specific dietary challenges, so perhaps swallow difficulties, or we're looking at the nutritional implications of not being able to absorb nutrients adequately. And then we also get really valuable, what's called qualitative data from patients or participants who give their perspectives on nutrition. And that's something I've personally looked into in research. And it's really valuable to get that patient voice. And one of the overlaying features we see with a lot of research is actually the terminology may not directly fit. So we might have older terminology, so the older classifications, so EDS type 3, for example, or we see quite broad generalized joint hypermobility, or groups are classed alongside other connective tissue disorders. So a population is looked at and then split into, we had X number of EDS patients, X number of Marfan's patients or participants, which makes it very difficult to generalize that information or the findings into just an EDS and HSD population, and then difficult to subcategorize it further to say hEDS, because recommendations for hEDS would be perhaps very different from a vascular perspective. So thinking about evidence around dietary regimes and protocols, as the title of this talk suggests, these are just some dietary approaches that you may or may not be familiar with or have heard about, perhaps even tried. And a lot of these can have very blurred definitions or less clear definitions. For example, the Mediterranean. There is certain definitions provided, for example, by the World Health Organization, but that's not just about the what is being eaten in a Mediterranean diet, it's also how, it's the social setting, it's the crockery being used even. So we have to think about, what do we mean by ketogenic, for example, and only when we can put specific definitions can we then be more specific about how we're researching them, but also why are they being used. So a low FODMAP diet, for example, is a clinical intervention used where there's a period of time of exclusion before a structured reintroduction that should be done under guidance, as opposed to somebody completely excluding the FODMAP or higher FODMAP groups forever. And so the evidence behind them is varied depending on what it's been used for clinically or in research purposes. So this is where some of the challenges come reading a piece of research or taking headlines and sound bites from them, because we have to think about what they've been researched for and what the clinical application is. So I've just picked out a couple of studies just to highlight what some examples that are out there, but also just thinking about how we need to think and consider the findings that are shown. So this, as you can see, is a paper looking at the gluten-free diet in POTS. And this was a small study with just 20 people, 20 participants, of which 11 had reported MCAS, 8 had hEDS diagnosis, 5 had both MCAS and hEDS, and 4 also had an IBS diagnosis. 18 of the 20 were medicated for POTS. But what's important to then look at is they were all already on a diet that was increased in salt and fluid. all had been screened negative for celiac disease, and they were trialed on a 4-week gluten-free diet. But some of the participants, and the paper doesn't say how many, some were already on a gluten-free diet. Only some started it as part of this process. The symptoms were self-reported around POTS, and the results showed a 10 to 99% reduction from the baseline that were taken at the start of the study. So on average, it was just around 50% improvement or reduction in their symptoms, but there were no what we would call objective measures to assess that. There were no POTS reassessments. No other interventions took place during this time, but there were no tests to help validate the findings. It was only self-reported. Now, self-reported symptoms are an important way for us to gather data, but we just have to take this, that whilst you could take a soundbite that 99% of people had an improvement in their reductions, there were only 20 people, and actually how much did they reduce their symptoms. So just one example as to we could really take the kind of positive spin on this, but actually we say, well, actually only 10% had improvement, and perhaps they were people who were new to a gluten-free diet, and whilst they were given some guided information on how to stick to and adhere to a gluten-free diet, perhaps it took them 2 weeks to actually really get to grips with that. So can we assess that over just a 4-week period? This is another example, and you'll see here the terminology is slightly different, looking at joint hypermobility syndrome, and this is using the low FODMAP diet, and this was in relation to irritable bowel syndrome. And this had a larger participant sample group of 165, of which just over 20% had joint hypermobility syndrome, 40% had an IBS diarrhea type diagnosis. There was also around 38% of IBS mixed, and around 20% had IBS constipation type, but they were all confirmed using the Rome 3 criteria. It was an 8-week retrospective study, so looking back, again using self-reported symptoms. And the information and the guidance was from a dietitian around using a low FODMAP diet. Some of that information was provided in a group setting, so around 60% received the information in groups of 10 or more, and around 40% of the participants had just one-to-one consultations with a dietitian. But all of the advice was formed of education, so dietary education around the FODMAP diet, menu planning, and developing a strategy for implementation. There were self-reported by the participants, an improvement or a reduction in symptoms, specifically pain, and specifically, more noticeably, in the group that had joint hypermobility syndrome. Most of the GI symptoms did improve. Bloating was the most significantly noted as a reduction in the joint hypermobile group. With diarrhea and or constipation, depending on the presenting symptom, also seeing some reduction. But it was only an 8-week study, and what's not clear from the study is, were those 8 weeks spent just on the exclusion period, and at what point, if it did during the study, were the groups reintroduced to assess for symptom presentation, perhaps. So again, on paper, this could look very positive, but we need to just understand more about the studies and look at perhaps a more specific sample population of hypermobile EDS and or HSD, rather than joint hypermobility as a broad definition. So just moving on to supplementation, because this often comes up when we're thinking about the evidence and people using supplements to just do that, supplement their dietary intake, so increase certain perhaps micro or macronutrients. Most primary research is typically looking at just a single dietary supplement, or perhaps herbal, but in this instance, we're really just talking about dietary. and sort of nutrient specific supplements. So they are looking at a single individual nutrient over a period of time, as opposed to a protocol, which is a term that's often used to refer to several nutrients altogether. So a single vitamin or nutrient or mineral or a fatty acid, or perhaps even a single strain of a probiotic or a digestive enzyme, for example. And this is a paper that is often brought to my attention, and sort of patients will bring to me, and it has been discussed for a long time because it was published in 2005, so it's almost 20 years old. But this was a hypothesis paper, so it was not tested, it was derived by the authors. It has never been tested either, and it proposes a protocol or a series of supplementation with quite general dosages that are based on evidence from other conditions that or presentations that we may see within the EDS sort of umbrella. But it does state that it proposes treatment, and again, only being a hypothesis, whilst it is an evidence-based hypothesis, there is no clinical guidance on this. It's never been tested to see were there any positive outcomes, were there any negative outcomes, which is as important to identify and research as a positive outcome. Were there side effects? Were there certain subgroups where a certain group of supplements just didn't have an effect or weren't tolerated? And we also need to think about how some of the supplements are formulated. Are they capsules? Are they a liquid? Are they a powder? So there's so many variables that if we just take this at face value, it perhaps does not transfer clinically to actually what we may do in practice. And another one that is often discussed is the Cusack family protocol, which I won't spend too long on, but it's just to really reiterate that it was compiled by the Cusack family for their own use. The research that they share as being what it's based on is selective, often does include animal studies. And again, it's not being tested. There are no clinical trials of utilizing all of these supplements, quite a large supplement list of 10 supplements together. And it does state that this is a lifelong requirement that people would need to be taking for. So it's always one that is approached with extreme caution, because any undertaking of a protocol should be done under the guidance of a qualified nutrition professional that is taking into consideration your specific situation. And the last paper just to really go through is this paper from earlier this year, 2024, that was done in the UK with 680 participants that were recruited from a support network and also a tertiary neurogastroenterology clinic. All participants had an EDS diagnosis confirmed, and information and data was collected through validated questionnaires. And very sort of brief findings here is that 62% of the participants reported that they had had dietary alterations. Co-occurring conditions was absolutely a factor in making those changes, and both supplements and in very specific situations, the use of tube feed, so enteral parenteral feeding, was also undertaken. But the biggest reasons behind making or most associated with altering the diet were conditions such as reflux, functional dyspepsia, MCAS, and also ARFID, so avoidance restrictive food intake disorder. And this is something, again, when we see this wider complex network of healthcare considerations and conditions, having nutrition and dietary guidance through a professional with use of multidisciplinary care is really important. So the next couple of slides just cover some of the findings of that, which I really encourage you to read through in your own time, just to be able to think about the findings of the paper, including the most reported nutrient supplementations that was used, and also how and where people are accessing nutrition advice. So just to bring it all together, nutrition and dietetics is absolutely a research that's an emerging area of research in the EDS and HSD world, but it takes time and funding. But I promise you that the ambition and the desire and the work is happening. It does just take time to come to fruition. The published primary data that we have can be really valuable, and it's often, whilst based on co-occurring conditions, we can absolutely look to how we apply this in clinical practice without overstating. And single interventions are often studied in isolation and they're not multifaceted. So this is where the clinical, again, the clinical experience of professionals really comes in to see how we can make that work for you as individuals. There's also some references from today, and thank you very much for your attention.